are back with an episode on IV diuresis after an extended break as I started residency. That also means the episodes are going to be a bit more sporadic, just kind of as I have time as I'm doing my intern year. Today we're going to be talking about part 1 with IV diuresis for adults. To start off, let's talk about a little bit of physiology. The loop of Henle is where about 25% of the total sodium reabsorption happens in the nephron. This sodium reabsorption is powered by an ATP-powered sodium-potassium pump, which creates both the chemical and an electrical gradient, which then allows the NKCC transporter to reabsorb sodium, potassium, and chloride, along with water, because we all know that water follows sodium. Loop diuretics work by blocking that NKCC transporter. This means that those ions cannot be reabsorbed and are instead lost in the urine, along with the water that follows them. Here's a table of the most clinically relevant loop diuretics. Something that's really important to note is that the oral bioavailability of furosemide is quite variable, anywhere from 10 to 60%. Absorption tends to be better before meals because food can actually interfere with the absorption. It also can be worse with gut edema, such as when a patient is in acute heart failure exacerbation. So oral furosemide tends to not be very effective when a patient's in an exacerbation. You can also see in this table the common conversion factors between the different dosages and forms of these different loop diuretics. Important to note that bumetanide or Bumex is pretty much equivalent oral and IV, whereas furosemide is a 2-to-1 conversion. Other factors important for clinical management is to look at the onset and duration of these different diuretics in their different forms. This will come up later when we talk about dosing intervals and times of the day. So let's say you have a patient admitted for acute on chronic heart failure, and you need to know how to start them on IV diuresis. A general rule for the starting dose comes from the 2011 dose trial published in the New England Journal of Medicine, saying that a good rule of thumb to start out is 2 to 2.5 times their oral home dose given IV twice a day. So for example, if they're on 40 milligrams of furosemide oral at home, you could start them on 80 milligrams IV BID in the hospital to get started on that IV diuresis. Or as another example, if they're on 20 milligrams oral at home, you could try starting with 40 or maybe even 60 milligrams IV twice a day. From there, you're going to evaluate how well you're diuresing them and adjust your regimen from there. In a patient with heart failure with reduced ejection fraction, so an EF less than 40 to 45%, this generally means that they have a weaker heart, and these patients are more prone to more extreme fluid retention. For these patients, our goal net in and out is going to be negative 2 to 3 liters per day. On the other hand, patients with heart failure with preserved ejection fraction, so EF greater than 50%, tend to have a stiff heart and don't accumulate quite as much fluid as in HFrEF. The goal I know for these patients is going to be a negative 1 to 2 liters per day, again, because they just tend to not accumulate as much fluid. The strategy of how to gauge the success of your diuretic regimens can vary. One way is to monitor the eyes and nose very carefully. You have to be careful here because the charted values are not always reliable. Situations when you probably can rely on those charted values would be if the patient's in the ICU, if there's a low nursing ratio, or if they have a Foley catheter or other way to reliably measure their urine output. In these situations, you can pretty much trust those charted values are reflective of what the patient is actually getting in and out, and is a good reflection of the success of your diuretic. On the other hand, situations where you need to have more caution with charted values include when your patient's intake may not be tracked super accurately, such as if they're getting food from outside, if you have a high nursing ratio, or if your patient is spontaneously voiding, because they may miss the hat, they might accidentally have an accident in bed, or they might urinate when they defecate, meaning that it's hard to track all of that urine. The overall is if it's hard to keep an accurate track of your patient's urine output, you need to be cautious with the charted values of their eyes and nose. Another strategy is to look at their daily standing rates. This strategy works great because the metric system is wonderful, and 1 liter of water is the equivalent of 1 kilogram of body mass, which is equivalent to about 2.2 pounds. So if you use this strategy, it's important to get a standing weight in the morning on the same scale before they eat or drink for the day. All of those factors are really important to make sure that we have consistent, reliable values day to day. This is also a pretty good useful metric to give patients to help monitor their own heart failure status at home after discharge. So in summary, loop diuretics work by blocking the NKCC transporter in the loop of Henle, thereby losing electrolytes and water in the urine. It's important to know conversion factors between the oral and IV doses of the different loop diuretics that we typically use in the hospital. When you have a patient admitted for acute on chronic heart failure, it's important to carefully monitor their eyes and nose to get to your goal diuresis. When you have a patient with HFrEF, your goal should be about 2 to 3 negative liters per day. Meanwhile, in HFpEF, your goal should be -1 to 2 liters per day. You can do this by monitoring their I's and O's if you're in a reliable context to be able to rely on your charted values, or you can measure their daily weights. In reality, though, you can diurese your patient as hard as those creatinine and electrolytes will let you. And this is a topic that we'll get more into in part 2 of this series. Big thanks to my advanced heart failure cardiology attendings at the University of Kansas, Dr. Sauer, Dr. Gupta, and Dr. Hagland. If you enjoyed this episode and found it helpful, please like and subscribe. You can find our website at decodingdx.com, where you'll find past episodes and show notes. Thanks so much, and be sure to watch out for part 2 of our IV Diuresis series.